Hello, future doctors. How are you all? Welcome back to MedStep's Internal Medicine Series, Episode 2. So, in our previous episode, we discussed about acute pericarditis. So, in this episode 2, we are going to learn about one of the most important and frequently tested topics in cardiology, that is valvular heart diseases. So, heart valves act like gates that maintain the one way flow of blood through the heart. So when these valves become narrowed or fail to close properly, then it leads to abnormal blood flow and eventually causes symptoms like breathlessness, chest pain, syncope, heart failure, and arrhythmias. So the four major valve lesions that every medical student must know. You can see here, so must have to know. So first one, like mitral stenosis, mitral regurgitation, and aortic stenosis and aortic regurgitation. So in today's section we will understand the basic mechanism of stenosis and regurgitation and causes of each valve disease and classic symptoms, characteristics of murmurs, and important ECG and echocardiography findings, and high yield exam points for FMGE, NEET PG, and USMLE and end rotation exams. So let's begin our journey into valvular heart disease, made simple and clinically oriented. So without time waste, let's start. So first, valvular heart diseases. We have total four different types of valvular heart diseases. But before that, we have to know, whenever we are listening, whenever we are doing auscultation in chest, we have to focus on, always we have to focus on systolic murmur or diastolic murmur. Okay. So first we are going to discuss about something about diastolic murmur, that is mitral stenosis. So this is mitral stenosis. So what is mitral stenosis? If you're seeing here, this is the main definition of mitral stenosis, that is we called the mitral stenosis means it's like narrowing. Stenosis means always we have to focus on. Stenosis means it's narrowing. Okay, so narrowing of the mitral valve causing obstruction of blood flow from left atrium to left ventricular during diastole. So most common cause you can see here, that is rheumatic heart diseases. So if any patient have rheumatic heart disease, that is the most common cause to get mitral stenosis. In mitral stenosis, we can see rheumatic heart disease. Next, we can see some calcification of valve, rheumatoid arthritis, ankylosing spondylitis, systemic lupus erythematosus, and malignant carcinoid. So if you are seeing here, some autoimmune conditions mostly you can see along with that rheumatic heart disease. Next, you can see malignant. So these are the main things will cause mitral stenosis. Why people get mitral stenosis? How this rheumatic heart disease will cause? So if you are seeing here, this is the main mitral valve. Whenever patient have rheumatic fever, the mitral leaflet will become inflamed. Because of inflammation, we can see fibrosis and commissural fusion. Then the mitral valve will become narrow, and we can see left atrial pressure will increase because of mitral valve narrowing. Then after we can see pulmonary congestion, and it will cause pulmonary hypertension. Then at last it will cause right heart failure. Okay, so that's why this mitral stenosis most commonly caused by rheumatic heart disease. Then after it will lead to heart failure. Okay, so next you can see here some clinical features. In clinical features, if you're seeing here, there is the first symptoms. You can see progressive dyspnea. Progressive dyspnea means difficulty in breathing. We can see. Next, we can see like palpitations. In palpitations is most common in atrial fibrillation. Okay, and we can see like heart failure symptoms like orthopnea and paroxysmal nocturnal dyspnea, PND, paroxysmal nocturnal dyspnea, and orthopnea, and we can see hemoptysis in severe cases and fatigue. Okay, so these are the main symptoms we can see in clinical features. Along with that, we can see some complications like atrial fibrillation or a stroke. Okay, or pulmonary hypertension. So these are the things we can see complications of clinical features, and we can see some signs of mitral stenosis, that is malleolus and tapping apex beat, hoarse voice we can see, that is we call Artner syndrome, and irregular pulse because of atrial fibrillation, and we can see loud S1 sound. S1 sound means we have to understand, that is whenever patient getting that S1 sound, it will become loud, and we can see opening snap, and we can see mid late diastolic murmur. This is the best heard in expiration. Okay, so these are the signs you can see in patient. So in mitral stenosis, we can listen some murmur sound, that is we called opening snap, classic murmur, opening snap, mid diastolic rumbling murmur we can call. So this murmur we can hear it in apex and left lateral position. So whenever you are listening this mitral stenosis sound, the patient have to lie on left lateral decubitus position. Then if you are listening the left lateral if you are listening, if you are auscultating, then you can listen very easily, and you can appreciate the sound also. And it can cause right sided like S4 if the pressure backs up all the way to the right heart. Okay, so this is the thing. And you can see here, and this in ECG, if patient have mitral stenosis, then ECG you can see like left atrial enlargement or atrial fibrillation. Okay, next in investigation, I already told may show atrial fibrillation or pulmonary mitral. You can see here, this is the, you can see like atrial enlargement. So that's why we call that is pulmonary mitral, like bifid P waves we can see. So next you can in chest X-ray, it may show pulmonary edema because of pulmonary hypertension and enlarged left atrium. Next, we can do echo. Echo is the best investigation to confirm the diagnosis. It will show the valve area and gradient and severity of the pulmonary mitral stenosis. Okay, so for treatment, we can go if patient have asymptomatic patients, it can be managed conservatively by following the patient clinically and with serial echo. So every 6 months, based on if patient don't have any symptoms, 6 months or 1 year, we have to do echo for uh, follow up. Okay, so if patient like have symptoms, so we have to treat medically. Like we can start with diuretics or long acting nitrates. Okay, so diuretics we are using for congestion, and use it to alleviate dyspnea, and beta blockers or heart rate regulation, calcium channel blockers, example like verapamil, and it can improve the exercise tolerance. Next, we have to, if patient have atrial fibrillation, we have to control the rate, we have to control the rate. If patient have if you're like if atrial fibrillation or if you're suspecting thrombus, we have to start with anticoagulation therapy. It's indicated for permanent paroxysmal atrial fibrillation. Next, we can go with in surgical procedures, we can go with PMC, means percutaneous mitral commissurotomy. It should be considered for symptomatic patients like severe mitral stenosis and pulmonary hypertension. So we can go with surgical valve replacement, like we called um, percutaneous balloon mitral valvotomy. You can do this surgery, these procedures for mitral stenosis. Okay, so what are the complications we can see in mitral stenosis? Means that is atrial fibrillation and heart failure and infective endocarditis. Okay, so next you can see here, that is aortic regurgitation, because first we are covering the diastolic murmurs. In diastolic murmurs, we can see mitral stenosis and aortic regurgitation. So now we can see here, that is aortic regurgitation. So in aortic regurgitation, the aortic regurgitation means whenever patient getting regurgitation name, that means we have to suspect patient have backflow of blood. So that is whenever regurgitation is there, that means black flow of blood is there. Like that we have to think, because aorta and left ventricle during diastole due to incompetent aortic valve, the blood will go to backflow. Then patient will get regurgitation. Okay. So what are the main causes causing aortic regurgitation? Means due to aortic root diseases. Aortic root diseases means like um, aortic root dilation, we call aortic dissection, and hypertension and spondyloarthropathies, example like ankylosing spondylitis. Okay, and along with that, you can see syphilis, Marfan syndrome, Ehlers-Danlos syndrome, like connective tissue problems. Okay, and you can see like infective endocarditis also can cause, and rheumatic heart disease and bicuspid aortic valve, and this is the connective tissue disorders also can cause this aortic regurgitation. How this aortic regurgitation will happen means you can see here. First of all, the aortic valve will fail. Then after the blood will returns to the left ventricle during diastole. Then the left ventricle volume will become overload. Then after the left ventricle will become dilated. Then reduce left ventricular function. Then after you can see heart failure. Okay. So these are the step by step it will go for aortic regurgitation. So we already discussed about this rheumatic fever, infected endocarditis, connective diseases, like rheumatoid arthritis and systemic lupus erythematosus, and bicuspid aortic valve. So next we can see some symptoms in aortic regurgitation. That is, symptoms will be like dyspnea, difficulty in breathing, and angina and heart failure. This is the main symptoms. You can see some signs. This is the main important signs in aortic regurgitation. So the in aortic regurgitation, the classic signs you can see here, that is the wide pulse you can listen. Okay, wide pulse like increased systolic blood pressure and reduced diastolic pressure, blood pressure you can see, and you can see some peripheral signs like water hammer pulse, that is water hammer or collapsing pulse. Okay, and Corrigan pulse. Corrigan pulse you can see, and Quincke sign. So Quincke sign means it's like nail bird pulsation you can feel in aortic regurgitation, and we can see wide pulse pressure and early diastolic murmur and mid diastolic Austin Flint murmur in severe aortic stenosis, and we can see another sign, that is thrombus sign. Thrombus sign means it's like pistol shot heard sound you can listen, like upper femoral artery, over the femoral artery, so you can listen. Then after you can see D Muset sign, the head nodding in time with each heartbeat. Okay, so in aortic regurgitation, with or without blowing head bob or bounding plus pulses, also known as brisk upstroke with precipitous downstroke, caused by large difference between systolic and diastolic pressure. So the main causes will be like bicuspid aortic valve, endocarditis, and aortic root dilation. So this aortic dissection may retrograde to the root, causing root dilation and aortic regurgitation. Okay, so these are the things. Next, how to do investigation. So we can check, we can confirm this diagnosis with physical examination. In auscultation, the classic murmur we can see, that is early diastolic decrescendo murmur. In physical examination, we can see early diastolic decrescendo murmur we can listen. Okay, so this decrescendo murmur we can the best heard in left sternal border. Okay, so in chest X-ray you can see, that is cardiomegaly, pulmonary edema, and dilation of the ascending aorta if patient have aortic dissection. Next, in ECG will shows like left ventricular hypertrophy. Okay, next we can do echocardiography for confirming the diagnosis and for knowing the severity, to assess regurgitation severity and left ventricular size and function. And we can do MSCT and cardiac MRI in severe case for further evaluation. And we can do cardiac catheterization may be used to assess coronary anatomy before surgery. Okay, so next you can see here, that is management. In management, mostly the patient with the mild to moderate aortic regurgitation can be reviewed yearly basis for check follow-up of echocardiography to perform every 2 years. If patient have symptoms of heart failure, then we have to start um, diuretics, ACE inhibitors, and ARBs and beta blockers. So we have to start vasodilators for to treat hypertension. Okay, selected cases we have to start ACE inhibitors. Next we have another option, that is surgery. In surgery is usually indicated like in symptomatic patients or asymptomatic patients when left ventricular functions begins to deteriorate. And we can do valve replacement remains the most widely used technique, and we can do valve sparing aortic replacement is increasingly employed in expert centers, like particularly in young patients. So we can go with aortic valve replacement. Aortic valve replacement. Okay, so this is for aortic regurgitation, and you can see here that is in complications we can see heart failure, arrhythmia, and infective endocarditis. Okay, so next you can see here that is now systolic murmurs. In systolic murmurs, first we can see here that is we called mitral regurgitation. So first will be like you can see that is mitral regurgitation. Regurgitations means I already told that is blood getting black flow. Regurgitation means backflow. Okay, so backflow of the blood from left ventricle to left atrium during systole due to incomplete mitral valve closure. So the main causes we can see here, that is mitral valve prolapse. Okay, this is a common condition occurring mainly in young women, and you can see rheumatic heart disease. Rheumatic heart disease, the main pathological condition, will cause mostly valve problems. So that's why now we are discussing mitral regurgitation caused by rheumatic heart disease, and you can see some papillary muscle rupture or rupture of cardi tendini or papillary muscle dysfunction, or you can see infective endocarditis, and you can see hypertrophic cardiomyopathy and Ehlers-Danlos syndrome. Okay, so these are the things you can see the main causes of mitral regurgitation. So in pathophysiology, if you are seeing means the mitral valve incompetence, you can see the blood will leaks into the left atrium during systole. So the left atrial volume will become overload. Then after the left atrial dilation, you can see, then after pulmonary congestion, then at last it will lead to heart failure. So next you can see here that is clinical features. In clinical features, next you can see some clinical features. In clinical features, you can see here that is some symptoms like difficulty in breathing and heart failure symptoms. You can see next fatigue and palpitations if atrial fibrillation is present. Next you can see some signs like irregular pulse in atrial fibrillation. Next we can see displaced apex beat, and you can see some signs of heart failure. Because of that thing, you can see heart pansystolic murmur, and it will radiate to axilla, and you can see like a soft S1, and you can see split S2 sound. Okay, so in mitral regurgitation, you can see here that is when the heart's pansystolic murmur will radiate to axilla. The main causes will be like endocarditis, left ventricular dilation, and early rheumatic fever, and post myocardial infection. You can see this type of mitral regurgitation. Okay, so next you can see here that is auscultation. In auscultation, we already discussed. Now investigation. In investigation, we can do ECG for atrial fibrillation, and P mitral for finding left atrial enlargement and left ventricular hypertrophy and atrial fibrillation. You can see in ECG. Next, in chest X-ray may be seen in cardiomegaly and pulmonary edema if patient have heart failure. Next, we can see like echo. Echo will confirm the diagnosis, and it will help to assess severity. Okay, so next you can see here that is echo will do liver will assess the severity of regurgitation and left ventricular function. So next, management of mitral regurgitation. In acute cases, the medical management with we can do nitrates or diuretics or positive inotropes. An intra-aortic balloon pump can be used to decrease to increase cardiac output. Okay, so if patient have any symptoms of heart failure, then we have to start with diuretics, ACE inhibitors and beta blockers, and like diuretics spironolactone we have to use. Next, in evidence for repair over replacement is strong. So in degenerative regurgitation, due to lower mortality and higher survival rates, we have to go with mitral valve repair preferred or valve replacement. Artificial valve or pig valve is considered. Okay, in acute severe regurgitation, emergency valve replacement is necessary. So in complications, we can see like atrial fibrillation and heart failure, infective endocarditis, and pulmonary hypertension. So next, you can see here that is at last main thing is that is aortic stenosis. This is the last murmur we have in systolic murmur. We have some pulmonary stenosis and tricuspid regurgitation, but it's not important because in valvular heart disease, this is four murmurs are very important. So that's why we are going to discuss now aortic stenosis. So in aortic stenosis means we already discussed before. Stenosis means it's like narrowing of the cusp. Okay, so whenever it's getting narrow of the cusp, what we have to do? So whenever patient present with aortic stenosis, the patient will get like soft S2 sound. You can listen, and it will radiate to carotids, and it will, we can say, delayed pulses parvus et tardas, and you can see if patient have aortic stenosis, you can see syncope also. Okay, so stenosis means it's like narrowing of the aortic valve, causing obstruction of blood flow from left ventricle to aortic during systole. So we can see some causes for aortic stenosis, that is degenerative calcification. The most common cause in patients we can see greater than 65 years. Next, we can see congenital bicuspid valve, like in younger patients, like less than 65 years old female, old patients, and you can see some post-traumatic disease or Williams syndrome, like supravalvular aortic stenosis or hypertrophic obstructive cardiomyopathy also can cause aortic stenosis. So the main pathophysiology you can see here, that is aortic valve will narrow, and you can see some obstruction to left ventricular outflow, and the left ventricular pressure will increase. Then we can see the left ventricular hypertrophy it will become. Then after it will reduce the cardiac output. Then after at last the patient will get heart failure. So we have one classic triad for aortic stenosis, that is we called SAD. SAD. S means syncope, D means A means angina, D means dyspnea. So this is the main triad we have, that the mnemonic will be like SAD. Okay, so the clinical features will be like you can see exertional chest pain and syncope and breathlessness and heart failure. Okay, so we can see some signs like narrowing pulse pressure and slow rising pulse, and you can listen some thrills in aortic stenosis, and you can see ejection systolic murmur radiating to carotids, and you can see soft and absent S2 uh, absent the second heart sound, and S4 we can listen. Next we can see that is auscultation. The auscultation, the classic murmur, you can see ejection systolic murmur, and ejection systolic murmur you can see that is like the main features will be like crescendo and decrescendo, and the best heard at right second intercostal space, that sound, and it radiates to carotids. Okay, next you can see in investigation. Next, you can see here that is in investigation, that is In investigation, we can do ECG. The ECG will help to will show the evidence of left ventricular hypertrophy, okay, and left ventricular strain. Okay, next we can do chest X-ray. The chest X-ray may show post-stenotic dilation of ascending aorta and calcification of valve. So next we can do that is echo. Echo will measures the valve area and pressure gradient. This is the echo is the gold standard for diagnosis of the gold standard for diagnosing of the echo. You can see here this is the X-ray. This you can see here this is the X-ray like post-stenotic dilation. You can see of aorta, of ascending aorta. Okay, so like this you can see dilation. Okay, next you can see here that is multi-slice CT scan. So in cardiac MRI, it may be useful for providing additional information to above prior to surgery. So next you can see cardiac catheterization. It will help to measure pressures across the wall to assess the severity of disease and need for intervention. So coronary angiography may be indicated as part of the assessment of coronary artery disease. Okay, so in management, if patient like asymptomatic, the patient has mild to moderate aortic stenosis, then the patient should be observed as a general rule. If symptomatic means, then patient should have valve replacement. If asymptomatic but severe with valve gradient, we can see that is also greater than 40 mmHg and with features such as left ventricular systolic dysfunction, then surgery should be considered. In treatment, in mild cases, we have to do follow-up. In severe patient have symptomatic, we have to do aortic valve replacement. The main options will be like surgical aortic valve replacement, or we have to go with TAVI. We have to go with TAVI like transcatheter aortic valve implantation or replacement. Or you can go with balloon valvoplasty is limited to patients critical aortic stenosis with are not fit for valve replacement. Okay, and we can see some complications. The same complications same to same like every murmurs like heart failure, infective endocarditis, systemic emboli, and sudden death. So these are the things. These are the main valves, murmurs, valvular heart disease. We can see here. So in simple, we can compare this mitral stenosis and mitral regurgitation, aortic stenosis, and aortic regurgitation. So in mitral stenosis, we can see the valve will be like mitral will be there. The timing you can see that while doing mitral stenosis will be like we can see problem in diastolic, and the main problem will be like narrowing. The common cause will be rheumatic heart disease. The murmur we can see mid diastolic rumble murmur. The burst location will be like apex. The radiation we can't see anything, but the main chamber will affected, that is left atrium. Okay, next we can see mitral regurgitation will be like main location will be the valve will be like mitral valve. The timing will be like we can see while systolic, and we can see the main problem will be like leakage, so backflow. Okay, the common cause of mitral valve prolapse and ischemia of that is a main cause of mitral regurgitation. Murmur we can see pan systolic murmur, and the best location you can hear that sound, the murmur sound in apex part, and the mitral regurgitation will radiate to axilla, and the main chamber affected like left ventricle and left atrium. Next, in aortic stenosis and mitral regurgitation will be like systolic. Aortic stenosis, the main location, the main valve will be like aortic valve, and the timing will you can see like systolic, and the main problem you can see like narrowing of the aortic valve, and the main cause will be like calcification. The murmur you can listen that is ejection systolic murmur. The main location it will be like right second intercostal space. Okay, and it will radiate to carotid, and we can the main chamber affected like that is left ventricle. So next diastolic murmur, that is aortic regurgitation. The valve will be like aortic valve, and when we can listen that sound in diastolic, and why? Because of leakage, because of regurgitation backflow, and we can see aortic root disease, that is the main cause. And we can listen that early diastolic murmur you can listen like left sternal border, and that radiation you can't see in aortic regurgitation and mitral stenosis. You can't see any radiation. In diastolic murmurs you can't see any radiation. Okay, and the main chamber will affected, that is left ventricular chamber. Okay, so mitral stenosis means its main cause will be like rheumatic heart disease, atrial fibrillation and opening snap. Mitral regurgitation means pan-systolic murmur radiating to axilla, and you can see SAD in aortic stenosis, that is sad triad, that is syncope, angina, and dyspnea, and carotid radiation you can see in aortic stenosis. Next you can see aortic regurgitation, that is like wide pulse pressure, water hammer pulse you can see. Echo is the investigation of choice for all valve diseases. The severe symptomatic valve diseases usually requires valve intervention. So this valve heart disease are not just memorizing murmurs, understanding the valve involved, timing of the murmur, pressure and volume overload and, and complications helps us to approach every patient clinically. So in the upcoming episodes, we will discuss about our other topics in cardiology. Okay, so thanks for joining the internal medicine series. So if you have any doubt, you can ask me in comment section. If this video is helping you, please like, share and subscribe. So we will meet in our next video. Till the time, signing off, Dr.